लाइव है? Okay. Hi everyone, so this is Dr. Sargam, and for those who have attended my lecture and those who have attended our Maha Revision on integrated channel, you must have found this very easy. So let us start. Which of these is a complication that is seen as a part of cataract surgery? If you look here, this is what you see. This is what is your intraocular lens. I have told you that normally the intraocular lens is kept in the bag. So what is happening here? Here your lens has subluxated downwards. So what is this condition called as? This is called as subluxation of intraocular lens. Let us look at the Maha Revision PPT now. So this was taught in Maha Revision, and as you can see, this is how your lens looks like. It has a center circle which you call as optic, and these are your haptics. And this is how you see the normal reflex from the fundus, and this is the normal margin of the intraocular lens. So normally your intraocular lens is like this, right? But what is happening in this condition? It has got subluxated downwards. So this is your subluxation of intraocular lens, and this has been taught already in the class and in the Maha Revision. Then next question, which investigation is used for this sign? This sign is called as Munson V sign. This sign is a characteristic of patients of keratoconus, and I have told you in keratoconus the investigation that we do is corneal topography. So corneal topography can be done either via Placido disc test, or it can be done via pentacam, or it can be done via orb scan. So this was the question, and your answer was pentacam. Now this is another page from your workbook and from your Maha Revision thing, and I have told you this is the Munson V sign seen in keratoconus, and management will include pentacam or orb scan, and this was your question. So this was another question that is directly from your notes, and that has been taught repeatedly in the class, revisions and TNDs. Now next question, what is the treatment of this condition? What are these? These are the perilimbal white papillae. These are also known as Horner's Trantas dots, and these are characteristic of vernal keratoconjunctivitis. Now if you look at the treatment of vernal keratoconjunctivitis, it is antihistaminics, mast cell stabilizers, and steroids in severe cases. So these two options, they were given in your exam as a single option, and your answer for this question was mast cell stabilizers and steroids. Now let us quickly look at your notes. So this is the same image that has come from your notes that was shown to you, that was repeatedly taught to you. These are the Horner Strantas dots, and the management of using antihistaminics, mast cell stabilizers and steroids and immunosuppressants, that has also been taught in both your class and your revision section. Then what are these referred to as? This question has also been asked in July 2026 exam. I have told you these are the nothing but your scars or the pits or the depressions that you see at the limbus. What are these called as? These are called as Herbert's pits. Again, this has been taught to you in your class notes and in Maha revision. This has been taught to you. This is the exact same image that you have got. So according to me, in this exam you have got, at least in ophthalmology, everything from the notes, almost everything from Maha revision. So our notes almost had a strike rate of 90% in this exam. Then what is the management of this condition? This is your pterygium that is encroaching the pupillary axis. Now I have told you, whenever you have a pterygium that is encroaching the pupillary axis, you have to go for pterygium resection along with autograft. What is the name of this pterygium resection that is done along with the autograft? The name of the surgery is perfect surgery. Again, this question was predicted and this has been asked repeatedly in your exams. This was a very important topic taught to you multiple times, and this is what you have been taught in the Maha revision also. So the perfect surgery has already been taught to you. Then with this sign is seen in which condition? If you see here, it looks as if the person is staring, right? Or if you see, there is some lid retraction in the primary gaze. I have told you multiple times that lid retraction in primary gaze is a characteristic feature of thyroid eye disease or Graves' disease. So your answer was thyroid eye disease. If you look here, this has been taught to you. This sign here referred to here is your Dalrymple sign that refers to the lid retraction in the primary gaze. So this has again been taught to you in your notes and Maha revision. Another thing is a patient with a history of ball injury to the eye. I have repeatedly told you this blood in the anterior chamber is called as hyphema. Some people confuse it with hypopyon. Now hypopyon is the pus in the anterior chamber and hyphema is the blood in the anterior chamber. Again, this is the same image that you have in your notes. You have this image in your notes and this slide is from your Maha revision and from your notes. So you have nothing that you haven't seen already. You have seen almost everything. What is this instrument used for? I have taught you in class in Maha revision. This is Jackson cross cylinder. Now what is Jackson cross cylinder used for? It is used for refinement of axis of cylinder. So that axis refinement is done by Jackson cross cylinder. This is a slide from your Maha revision. in which I have taught you this Jackson cross cylinder and astigmatic fan test, and this is a slide from your notes in which I have written the same point that it is used for subjective refinement of the axis of cylinder. So everything has been taught to you that you have got in the exams. Then which drug is used to break synecdoche? This pupil that is alternatingly dilating and constricting, this pupil is called as a festooned pupil. You all know that. Festooned pupil, it is a characteristic of anterior uveitis. Now, what is the drug that is used to break? So, if you give a drug that acts as a mydriatic, it will break the synecdoche. So, what are these drugs called as? These are your cycloplegic agents. And what are the cycloplegic agents we have? You know, we have atropine, we have cyclopentolate, and we have homitropine. So out of these three, if you want to ask which one is used most commonly, so we use a longer acting, and you know that atropine acts for 7 to 10 days. So what will be the drug that you will use in this condition? Your answer is going to be atropine. Again, a concept that has been taught in the class. This is from your Maha revision. Again, I have told you in management you give steroids and cycloplegics. Cycloplegics, you know, atropine, homitropine and cyclopentolate. Then another question is, a child has a vision of 6/6 in one eye and 6/16 in another eye with -4 diopter square. If you look here, the difference in the Snellen's chart is of more than 2 lines. You know, whenever the difference in the Snellen's chart is of more than 2 lines, or when the power difference between the two eyes, it is more than or equal to 2.5 diopter square, it leads to a condition which you call as amblyopia. Now, amblyopia, you know, it is of different types. It can be either because of squint, so you will call it as strabismic amblyopia, or it can be because of the difference in the power of the two eyes, as you can see here. Okay, so your answer is going to be an isometropic amblyopia. This is your answer. Again, a concept that has been repeatedly taught. I have told you amblyopia is one topic you are going to get in every alternate exam, or probably in every exam. So there was no point on missing out on this topic. This has been taught here, an isometropic amblyopia, like the power difference between the two eyes is more than 2.5 diopters and the difference of at least 2 lines on Snellen's chart. So this slide is from your Maha revision slide. Then what is the treatment of this condition? This is a dendritic ulcer that is characteristic of viral keratitis. Now, viral keratitis, you know, in viral keratitis you will go with antivirals. So, what is the drug of choice? Your treatment is going to be acyclovir or ganciclovir. So this is how you manage this case. Again, a slide from your Maha revision, viral keratitis, the same image you got in your exam. I told you that these are the dendrites and the management will be 3% acyclovir ointment. Then what is the management in this condition? So this was not taught in your notes, or this was not even taught in the Maha revision. This is a new question for you people. This has been a previous INI CET question. So what is this called as? This is a limbal dermoid. Now what is the management? So management of limbal dermoid, if it is small and it is at the limbus, you will simply just excise the dermoid. But if it is big and if it involves the cornea, then you have to cut this part also, right? So there will be a defect in the cornea, so you have to replace that part of cornea also by doing lamellar keratoplasty along with the dermoid excision. So I don't know whether this image was given in your question. If this image was given, your answer will be lamellar keratoplasty along with the excision of dermoid. And if in your question this was the cornea and just here at the limbus a dermoid was given, then your answer would be just excise the dermoid. So basically your answer that depends on the exact size of the dermoid that was given in the question. Now what is this image shown as? This is your symblephron. Again, this has not been taught to you people. So this commonly occurs after chemical injury. Now what happens in symblephron? Your bulbar conjunctiva, that means this conjunctiva, and the palpebral conjunctiva, they are adhered to each other. Okay, so the bulbar sigma rules, I don't know, you people only have given me the recall question. So if it is given to me, that's why I'm discussing, no? Are you talking about limbal dermoid or are you talking about symblephron? Okay, so symblephron, what happens is bulbar and the palpebral conjunctiva, they are attached to each other. So if you tell me, okay, that is great if limbal dermoid is not given, that even increases our strike rate. So that is a good thing, no? Because even we haven't studied and that is not in your question. So that is great. That is good for us. So this is your symblephron. This has not been taught in the class. So when is LASIK contraindicated? What is LASIK? So basically LASIK, I have told you, it is a refractive. This was taught in the class. So LASIK is a type of refractive surgery. So when is LASIK contraindicated? LASIK is not done when the person is less than 18 years of age. So you had a question that said that LASIK is contraindicated, and there were different scenarios that was given. Number one, it is contraindicated in child less than 13 years, or the stromal bed, it is more than 450 micrometer, and some more things were there. So remember, LASIK answer was this: LASIK, it is always done in a person who is more than 18 years. Another thing is the number has to be stable. So if I want to go for LASIK and my number today is minus 2.5, after 2 months it is minus 2.75, then say after 3 months it is minus 3. So my number is changing, right? If my number is changing, it is not stable, then I am not a fit candidate for LASIK. So LASIK is done when the number is stable, the person is more than 18 years, and when the residual stromal bed thickness it is more than 250 micrometer and your corneal thickness is more than 450 micrometer. What does that mean? See, if this is your cornea, this is your cornea, you make a flap like this, you give the laser rays. So here you make a flap of the epithelium. So you have to see the residual stromal bed. This is the residual stromal bed. So this thickness has to be more than 250 micrometers and the overall corneal thickness has to be more than 450 micrometers. So this was not taught in Maharevision, but this has been taught in your classes. So if you look out of these, if we don't include this question of dermoid, then except for one question, everything was from your notes, everything was from the revision session, that 4-hour revision session you had. So I hope you were able to solve the questions and the revision and the notes helped you people, and waiting for good results from you people, and see you on another side of NEET PG. All the best. Bye. Take care. And now don't get disheartened if the exam wasn't really well. Just wait for the results and then only decide your further course of action. Bye. Good night.